Well, good afternoon. It's good to see you again. And thank you for being here. You know, there's so much changing at any given moment in time. I'm just grateful that you're here, that we can have this conversation and share high quality information and hopefully clear, consistent messages with your audiences. So thank you for being here. Let's talk first about the number of coronavirus cases in the state of Kansas. They continue to increase in number. We knew that was going to be the case, at least for a while. We now have confirmation of 202 positive cases in the state of Kansas. That's 30-some more than yesterday. We have added one additional death, unfortunately. We have 4 deaths in the state of Kansas, 3 in Wyandotte County and 1 in Johnson County. There's some good news to report, and that is our lab is continuing to improve and increase the testing throughput. We are now managing about 175 specimens a day, but we have some good news on the horizon. We have one new piece of equipment coming in this weekend and a second piece next weekend that will turn us into more of a high throughput laboratory. Because as you know, and I've shared my frustrations quite honestly, that we would like to do more testing and population-based testing than what we've done. And yet we've been limited by the amount of testing we can do. High throughput, we're currently at 175 a day, give or take, as I mentioned. The new equipment will allow us, when it's up and running, we'll need to go through some validation testing, which hopefully we'll get it online by the first part of next week. We'll have us at about 700 per day to maybe up to 1,000 per day, and I think that'll actually meet our needs. There's always a rate limiting factor though, and we still have to have the swabs that you take the samples and the test and the medium for transporting the samples. Those are still lagging a little bit, but we're applying those supply chains, and hopefully that won't be the limiting factor. Protective equipment. There still is a severe worldwide, this is just not in Kansas or the United States, but a worldwide shortage of the supplies, and we are continuing to work our supply chain. We continue to not only receive, we received 2 semis full of equipment yesterday from the Strategic National Stockpile, which is managed and dispersed by FEMA. 2 semis yesterday, and today's a good example. We'll be filling 25 counties' request for equipment. I will also mention that in terms of protective equipment, we fill orders 7 days a week. This is not a Monday through Friday thing. Coronavirus or any infectious disease emergency doesn't act that way. The Strategic National Stockpile is not an endless stockpile, unfortunately. And again, it's something that we don't control, but we try to make sure we get our share. And within about the next few days, I think we will pretty well tap out the 100% or so that we're going to be allocated of the Strategic National Stockpile. So one of the things that we're continuously looking for is how do we manufacture, how do we, even within our own state, reconfigure companies to develop masks, surgical grade gowns, and even gloves. We're looking at an opportunity with a company here to develop the capacity to make non-latex containing gloves for for keeping our hands clean, that kind of thing. Some interesting news, again, back to the lab. The Cepheid is a company that we've been working with. They just got approval on the 21st of March. So this is very much a moving target. And it's just on the 21st of this month, and what are the 27th now, that Cepheid got emergency use authorization to have their technology deployed to our laboratories. And that's a 45-minute test. So that'll dramatically improve the throughput through our system. Additionally, there's a company called PerkinElmer that we're using that extracts the DNA and the genetic material out of the samples that come to us. And that is a very high capacity. We hope to acquire up to perhaps even 65,000 test kit kind of capacity, if you will. And I think that's encouraging. The lab is running 7 days a week. It's, again, not a Monday through Friday thing at all. And why do I bring this up about the testing? Is because, as you know, we've been limited in the testing capability, but it ties in directly to the projections for where we're going to be. I think we're getting a little bit tighter projections in terms of what we think is going to be the trajectory for this illness. We've used University of Washington data. I was working with some experts today that have developed a nationwide method, both for the United States as a whole and state by state by state. It looks like that we've developed our own capability within our own agency and within our own state for doing these projections. And it's a little bit like if you think about projecting weather or forecasting weather, you're always going to be better at tomorrow. You're going to be really hard. If I asked any one of you to say, what's the weather going to be like in 30 days from now, you wouldn't have a very good clue. But from tomorrow, you'd have a pretty good clue. You'd say it's pretty much like today, probably. Although this is Kansas. One of the things, I think that what we're doing is triangulating in the best projections we can, and I think that we're probably going to see the coronavirus peak out in the state of Kansas probably in the middle of April to maybe as late as the 24th or the end of April. And the reason I say that is because we still don't have the ability to do widespread population studies because we don't have the testing necessary to test sick people, well people, people that are around the people who have been sick, to really understand what the population dynamics look like. But I think our forecasting, now that we've unfortunately got more cases of the illness, we're getting better all the time at these forecasts. Additionally, and this is a subtle thing, but I think it's worth mentioning, and if you go to our website, you can see where our influenza numbers are tracking like this and are on their way down. That's for influenza. In reality, that's for influenza-like illnesses. It's for people who present with influenza-like illnesses, fever, cough, muscle aches, and the like, shortness of breath. And one of the things we've seen is the influenza tracking down, but it's on the way back up. But it's not influenza that's doing that. It's probably the coronavirus. We're digging into this because that's, again, it's a tracking of influenza-like illnesses. We're going to look statewide and look at where are our defined coronavirus cases coming up and how does that compare to the influenza-like illnesses that we are seeing. And I actually think it's going to be very helpful for understanding where are the cases that we know about. We know about those, but where are the cases we don't know about? And the reason is that this dovetails into the discussion, okay, with the various stay-at-home orders, shelter in place, et cetera, how do you ever know when to not shelter in place anymore? How do you know when to not necessarily be so restricted? These are the kinds of forecasting data that will help us to know when to take people out of and to become less restrictive. Last couple comments. There's counties that have been involved. There's the population centers, particularly of course, Johnson, Wyandotte, Douglas, and Sedgwick have had the most cases at this point. This is exactly what we predicted, where you have the most people is where you're going to have the most disease. But it's spreading out even out into western Kansas and Gove County, et cetera. So I think we're going to see some things pop up like this. And I think it's going to call out for an approach. Not sure exactly what that means yet, but we're getting a better feeling and for how is this disease acting, what are the spread dynamics, and then importantly, what do we do about it? We have a number of groups working, and I met with them early this morning. One of the groups that says, okay, let's look at a metropolitan area like a Kansas City, Kansas, Missouri. And when you think about KC, the metropolitan area, that's one metropolitan area. The state line essentially makes no difference when it comes to this. So we're working closely with Missouri. We've had good cooperation with Missouri to get the data. Because when the going gets tough in intensive care units, we will share patients, we will route patients where they know that for Sedgwick County and then for the smaller centers around the state. If we make the assumption, and I'm using the University of Washington data, I haven't talked much about that, but there's a really good modeling tool that came out of the University of Washington. Washington State, as you'll recall, was one of the very early states. It was the earliest problem state. Developed a tool, and they have it for each state. And this is really reassuring to me, and hopefully it's accurate and will remain accurate through time. If we say that April 24th is the peak day, and then it'll start leveling off and going down, on that peak day in the Kansas City metropolitan area, we're only down behind, if you will, by 35 intensive care beds. 35 we can absorb in the system. As one of the critical care docs said, we do that all the time. And when you think about it, everything from North Kansas City to, to the St. Luke system, KU, et cetera, that's something that can be absorbed within the capabilities without having to say, let's build something, let's hotel, let's borrow a VA hospital, borrow a children's hospital, whatever the solution might be. Having said that, we are not resting on our laurels. And presuming that the numbers are exactly correct for April 24th, that's everything we need, we are still looking at what we refer to as alternative care sites, should we need to use Army Corps of Engineers, the National Guard, et cetera, to build out a facility that we're currently not using for coronavirus patients. So I think on balance, that I'm feeling a little bit relaxed about the comfort we're getting around the numbers and the ability to accommodate what's coming down the pike. Are we going to continue to have more cases? We are going to continue to have more cases until we peak out, and then it will slow down. And I'm hoping that the numbers are going to hold true in middle of April, middle to later on in April, I think will be when we peak out and start coming down. Questions, comments?
The doctor?
Yeah.
The shelter in place, there's no way you can say, well, we're going to keep that shelter in place until we have zero. That's not doable. But that being said, are you not concerned, though, that the shelter in place goes away, that you got those few people out there who are going to be out and around, and then it just starts all over again, I'm sure?
Right. Good question. The question is, okay, it's sheltering in place. How do you know when to not shelter in place and to cut people a little bit more slack? And the answer to that is, I think that we really will need to evaluate week or every 2-week increments to say, where are we now? Because it's changing that fast. I'm sure we won't go and say, okay, we've been on voluntary shelter in place right now, or voluntary stay at home. And a lot of counties, of course, don't have that in place at all. But if let's just say it were a statewide program, if you will, at what time do you say, cut you a little slack? I think it's after we plateaued off, and then people go to being prudent at that point. We're not going to say, okay, you can go from maximum of 10 people in a mass gathering to 250 or more. It'll be a graded thing, because there's still going to be disease in the community. But if it's on the downturn, I think, and we get ahead of it, it's going to continue on the downturn as long as people use common sense and don't push it.
So what's the message for people right now in terms of, that they hear, we hear you saying that you're feeling a little more confident based on what you're seeing right now, but if you're in Johnson County or you're in Lawrence and you're being told to pull up still, I mean, what is your advice to people right now? What do you want from them? Great
question. In those counties, and really all counties in Kansas, even if there's no cases having been diagnosed, I suspect that as you get more and more cases throughout the state, there's going to be more and more spread, even if it's not diagnosed yet, more and more opportunity for spread. But to your question, what do I recommend? I do not think people should take their foot off the gas. They should stay home. They should continue to hunker down. And, we've not been at this very long. And I would not let up a bit. I think the vigilance needs to remain high and not push it, stay home, and do all the things that are necessary to maintain the social distancing and disease spread kind of mechanisms of cleanliness and whatnot. I wouldn't let up a bit.
So your projections, your optimism now is based on them complying with that, is what you're saying, is based on people taking that seriously.
Yes, and I do worry that people are still not taking it as seriously as they might. You've heard me, I won't say rail on, that's a little bit too loud, but I've been concerned that people say, oh, this is a necessary function because I need, automotive mechanical repair is important, so I'm going to go get my car, I'm going to go wash my car. Well, that's not really a necessary function. And I drove by here in Shawnee County, a multi-bay car wash where you get out and do your own car washing. It was full, and there was people lined up behind those cars. And I'm thinking that is not working when people, because that's not a necessary function. So I still think that people need to say, this is not about gaming the system and playing with words to skate around the exceptions and the exemptions. It's really about taking it seriously and staying home, staying out of harm's way, and keeping people out of the harm that you can cause. So I think it's really important that people stay very serious about it.
When you say this will peak in mid to late April, what do those numbers look like? How many people are you projecting?
I think that, I don't think we're not doubling every 3 to 4 days. It wouldn't surprise me if we would be to 900 to more than 1,000 over that period of time.
Do you have an idea of how deadly this might be for the state?
Well, I would just look to what we're doing now. We're this far into it, and we're going to continue to have deaths, I hate to say. But if we can sidestep and not have the same things that they saw in Washington, and especially the things that we're seeing in New York, I think it'll be much lower fatality rate than that.
How can it be different here versus there? Are we doing something different than New York's doing, or is it just because it was earlier there?
Good question. How can we be different than New York with its many, many times multiples of what we have here? A couple things, and it's interesting, and I'll share a little story with you. My son lives in Brooklyn, New York, and he has coronavirus. He's at home right now. He's on day 5 of the illness, and he and I are in communication daily, as you would expect. He and is doing fine. So I talk to him just every day, but again last night, and I said, so how is it there? They don't even test anybody now because they all have it. Anybody that's sick has coronavirus. The streets are empty, but in New York, I think people are on top of each other. It's all mass transit. They are all close together, but now they're taking it seriously. I think they were maybe, as to your earlier question about do people really take the root of your question is, are people taking this seriously? At least that's what I interpreted it to be. I think people there take it very seriously. So I talked to my son about this. I said, so are you going to go out to get tested? He said, well, there's no testing to be had. And I'm not sick enough to be hospitalized, and I think I'm getting better. And he said, besides, it's a ghost town out there, and people have just gone hunkered down. You don't see, it's like a zombie movie. It's so weird. And I saw that as a good thing, but it's a little bit slow on the uptake. And I think that one of the things we've done here is that things happened on the coast earlier, and I think we have learned from that. And every day we could push this down the road, especially, and we haven't talked a lot about seasonality. I think there will, and I'm knocking on wood as I say this, I think there's going to be a seasonality component to it, and I think we're going to be naturally blessed by having April and May come in with springtime. And the pundits that are smarter than I am on this forecasting suggest that the numbers will drop down and then probably come back up again in the fall as a seasonal disease. But by that time, we will have a whole lot more planning efforts in place to really get ahead of it. So I think that we've learned from what's gone on in other areas. I've commented before on the fact that we've got best practices research going on within our agency and within our command team to really understand what has been successful other places and what hasn't, and then to incorporate those things as best we can. And it's a delicate balance, and I haven't done the scales yet, but it's kind of how invasive are we versus how much do we allow life, commerce, child care, et cetera, to go on, because it would be almost easier to just to be draconian about it from the very start, and yet that's not necessarily the best thing for maintaining the fabric of society either. So we've tried to always have a measured response. What we're seeing, 1, 2, 3, 4 weeks ahead, what should our response be now to anticipate? The old great Gretzky thing about you don't skate to the puck, you skate to where the puck's going to be, and what we try to do is to skate to where the puck's going to be in about 3 weeks.
If more counties don't have shelter in place, stay-at-home orders, or people don't listen to their counties, are you factoring that into your numbers, or could they go higher than that?
Yeah, we do. The question is, do we factor people movement essentially into it? And first, a gut response is, I wish people would do what we say, but they don't. So then, therefore, is it necessary to invoke some kind of an order to make it more restrictive? And the answer to that is maybe. We do monitor. And we're even looking at GPS tracking. Everybody's got a cell phone these days. And we know, for example, are people moving more now or less now than they did, let's say, 3 weeks ago? In terms, when you look 3 or 4 weeks ago during spring break, you looked at GPS tracking or GIS tracking of cell phones, it was global. People were going everywhere, and even regionally. Now, when you look at tracking, such as one can do on a cell phone, people aren't doing that. It's been a 40% reduction of people movement. So I think partly it's because it's not spring break anymore. Partly it's very obvious how bad this is going worldwide, but especially in the United States right now. And people are saying, I've gotten the wake-up call. I'm going to hunker down. But we cannot ease up on that. We have to keep going.
We're still getting a lot of questions about testing. I realize we're not in New York, but people are still saying that they're having problems accessing tests. I know there are a lot of pieces to this, but I wonder if you could walk me through again. So, Kansas is increasing its throughput, but what about the materials? And then
Right.
Are there enough private labs online, or are people maybe bumping into, they can't get testing through their doctor because their doctor can't find a private lab? And how many hospitals are coming online with in-house testing?
Yeah, good question. This is about the whole gamut of testing for coronavirus. One is, and you'll see it on the handout today, that, and this is, I think, a very good sign, that of the positive 202 cases, 135 came through private labs and 67 came through our Kansas State lab, which means to me there's more and more offices and hospitals that are using private labs, because to us that's a good thing. We want to be able to preserve, and I talked about this early in the week, we want to preserve our Kansas Health and Environment Lab for first responders, for healthcare workers, for patients that are hospitalized, for people that are in high-risk groups, and not just to have it be the general public. There are enough between the Cahill, even with our current functioning, and the commercial labs, we have enough capacity to test anybody that is ordered. But a physician or a patient just can't go and request it. It has to be ordered by a physician or by a hospital. But there's enough capacity to do it now. But people do have to route in through it. Will we at some point in time, and we've looked at this, will we have testing stations that are in other locations around the state? We've talked to Hutch, we've talked to, of course, the metropolitan area, including Lawrence and here in Topeka and others. And we might have a more community-based answer to this. We haven't gotten to what I call population-based studies, which is, are you and you positive for this right now, and could you and you be the ones spreading it? And we don't really know the answer to that yet. And that won't come anytime soon, because that'll be a research use, really. At this point, we're still devoting to containment, mitigation, and treat of the disease and treating patients. One thing I was going to mention, it's going to be fun. I think it's going to be helpful, and that is, matter of fact, on Twitter account today, there's a new video that I just put out that actually my team did about coronavirus, the questions that kids ask, and because nobody's talking about kids. And one of the things that I know, I talked to my grandson up in the Seattle area, actually, not too long ago, and I said, what are you thinking about these days? And he said, I live in Bellingham, and coronavirus is going to come here, and we're already out of school. And I said, what do you think about? What do you worry about? So I gathered a bunch of questions from children, 6th, 7th, and 8th graders, and have gone on. I think we have 4 brief, 2 to 3 minute videos that we're going to be putting out that are coronavirus, questions that kids ask. The first one came out today, and I have to say it's pretty good, and it's very relevant, because I'm answering kids' questions that we might not think of as adults. And I don't know the exact. I know it's on Twitter. I don't know if it'd be available anyplace else, but I think it's really going to be something would be worth showing it to children, particularly of a certain age, maybe third to ninth graders or something.
What's the biggest question that they were saying?
You know, it's fascinating. It's everything from did China invent this to kill other people to am I going to die? Are my parents going to die? Do I need to stay away from grandma and grandpa? Is there a cure? I mean, where'd it come from? You know, until you open up the phone lines and ask kids what they're asking, and what they wonder about, you don't have a glimmer, because we think they're sitting over there off the corner playing with something or doing something else. We think that they're not paying much attention, and they're just soaking it up like a sponge. And I think we really need to open up those discussions with the kids as well. And this is just something to provoke thought. One more question.
So we have more
Sure.
nurses and doctors kind of on the front lines of this, or bracing for the onslaught. I just wonder, you know, as a soldier, you're asked to go put yourself in harm's way, and as a medical professional, you know the risk. I just wonder what you would say to sit them down and help ease their apprehension about this.
Yeah, well, first and foremost, and that's a really good question, how do we work with, assure, and equip medical professionals, doctors and nurses who are in harm's way? And I remember going through this with Ebola in 14 and H1N1 in 2009 and SARS, the earlier one. And that is, we have to arm them with information. What's this about? Second is we have to provide the necessary protective equipment. And in this case, we've been strained on that. We have to prioritize. For example, we've requested dentists and others who do routine, non-emergency things to cut back, because they're using a fair amount of protective equipment. We need to shift that to the people that are the front lines, that, you know, because traumas are still coming in the door and babies are still being delivered, and those guys need to have the right equipment. We're looking at novel ways to deal with that. For example, we're looking at UV sterilization, ultraviolet light sterilization, so that we can reuse safely masks more than once. We're looking at surgical grade cloth to make gowns with and masks with. But at the same time, I don't want to think these novel, and by the way, thank you very much to the people who are thinking of these novel approaches that might help extend the life of our current products, or to spread out so that we always have enough equipment available. But we're looking at novel ways to make our own, buy our own, reuse our own. But I do not want to do it and jeopardize the health of our workforce, because they're really critical in the front lines, as you point out.
Any words of comfort for the stress?
You know, healthcare workers, and I've spent 42 years of my life in hospitals, are very altruistically driven, and will, as long as there's a measure of safety that they, and importantly, their families, will remain safe, I think will continue to show up and do the great work. When we had Ebola patients that came in sick with perhaps Ebola, we had no shortage of volunteers, but it was because they were armed with knowledge and the equipment to do the work they did, or needed to do. So thank you very much, guys.